Yeah. Come on, beautiful babies. Chop, chop, let's go home. Come on. First page, pre-op checklist. Chop, chop. Lou, let's go. Lou. Okay, now, let me show you. This is just as important as everything else we talked about. Do not ignore this one. This is all the intra-op, pre-op. This is a lot of questions. Don't ignore this one. Maybe, I don't know what you got to do, but put very important or some shit. I don't know. Now, the front page. The front page. Here's what I need you to put. If you look, it's a very, very appropriate checklist. Look at it. What is the most important thing on that page? Informed consent. Because you might as well turn that child around, because she ain't having surgery today without it. Informed consent is the most important one, because you guys know you got 5 reasons you can call the doctor first before doing anything. Why do I need to make her allergy bracelet? She ain't staying. She ain't got no consent. Wasting my time, hell. I'm a busy woman. Okay, I ain't finna make you no ID badge. I don't even care what your name is. I don't see none in your chart. You have to take it very seriously. And just as important as her having or him having a signed consent form is that the patient knows what the hell is happening to them. You will never forget my story. I tell it every chance I get. I floated to ambulatory healthcare, ambulatory surgery as an RN. I ain't thought nothing of it. All I kept thinking was, this gonna be an easy day. They gave me a hysterectomy, vag hyst or some crazy shit. I walked down there. I go introduce myself to this delightful patient. I say, hey, how you doing? You know, I'm Mickey Mouse, you, whatever. And I'm checking everything. The consent is signed. Let us not forget that it was signed. I said, okay, so you know what we're doing to you today, right, Mrs. So-and-so? She said, oh, yes. The doctor said he's going to fix my periods. I said, that's true. That's a good way to put it. Certainly you ain't going to have none when we take your uterus out. She said, huh? What you say? I said, well, you know, we're taking your uterus out. We're doing a hysterectomy today. Oh, no. He ain't said nothing about taking my uterus out. I said, oh, hold on, honey. I walked over there to that physician's lounge so fast. That doctor was so angry with me, yelling at me. We used to it as nurses, like, whatever. You better go in that room and talk to that patient, because ain't no surgery happening up in here, and she don't know what's going on. Then he starts yelling at the patient, which I thought was horrible. Miss So-and-so, you know that you're supposed to be having a hysterectomy. I told you. You ain't told me. She got louder than him. You ain't told me nothing. Now, her and her uterus walked out that day. She left with her pieces and parts. She was gone. She wasn't having that. You ain't told her about no pieces and parts missing up out of her body. She had a strict opinion that if God put it there, it should stay. And she walked out with her uterus. That was profound. My colleagues, your colleagues, would have walked in that room just as good, put that IV in that patient, got them fluids running, boom, ready to go to surgery. It's not a patient advocate if they don't know what you're doing. It's called advocacy in your ethical language. You are a patient advocate. Every time you check for consent and you check if she knows what's going on, it's called patient advocate. Okay, you don't want to do stupid stuff, so this is most important. Now, of course, we probably should highlight that ID band, because I have very seldom, but I have seen it. Very seldom. I want to be clear about that. I've been practicing 30 years. But very seldom. I have seen a person in the OR without one. Yes, they got there relatively quickly, but they had been there when I came on. So by now they should have one. So you know, it is a lot of stuff that goes crazy on a day-to-day basis. But even if you're coming in the middle of the shift on a surgery, just check the wrist for an ID band. You don't want to mess this up, because if she has a problem in surgery that takes her up out of here, you got to have an ID band on. You're crazy not to do that. Okay? All right, so ID band would be the second most important thing. Allergy band comes next. And then I want you to highlight where it says void prior to transfer on the left-hand side. Here's our deal, everyone. We understand that for years we have been doing unnecessary procedures on patients. I'll give you an example. I have tied tubes forever. It would be an unnecessary procedure if I had the nurse put a Foley catheter in the patient and I'm going to tie some tubes. Why would I do that? The freaking surgery takes me 15 minutes. And you know, every time we put a catheter in a patient, we run the risk of having a hospital-acquired or nosocomial infection. So what we do now for patients that traditionally we always put a catheter in, we strategize. If the surgery is only going to be 2 hours long max, we don't put Foleys in. And so what does the nurse have to do before she's completely humiliated because she didn't do it? She has to take the patient to the bathroom on the way to the OR. They've got to go right before you move back. Now, you're going to get confused if you don't do this right. Because a lot of people say, oh yeah, as soon as she got here, she went to the bathroom. That's true. But since then, you've hung a bag of fluid. She has to go again right before, so we don't have a patient sitting up for her anesthesia talking about, I got to go. Okay, so they got to go right before. That's why it says just prior to transfer. It doesn't matter that they went when they came in. Remember what your patients are taught. They're taught to come in the surgical suite 2 hours before their surgery. You had her go at 6. It's 9 o'clock now. Have her go again. Now, under informed consent, write this word. You got to know what this means. When is implied consent needed? When is it that we say, oh, we already have implied consent? When do we look for that? Emergencies. Unresponsive patients. Emergencies. The consent is implied because we just believe in our heart of hearts when we say, is it okay if we do this surgery? If we don't, you will die. You go, you know what? Go ahead and knock yourself out. We believe that. It's implied. Now watch it on this one. This is not for elective scheduled surgeries. It's not. It's only for emergencies. It's only for unresponsive people, comatose, coded, all the stuff that be going on in the hospital. If you can give me a consent, you can sign for a consent. And if you can't sign, it's okay even with the verbal, but really, honestly, implied is emergency. Never an elective surgery, never. Okay, so that's a big deal. Then I want you to remember where it says skin prep, we use chlorhexidine. What's the brand name? Anybody know? For chlorhexidine? You've seen it, but you don't know it in the hospitals. Hibiclins. But it's chlorhexidine to you. Okay, turn the page. You should have, unless I screwed up, something to say day of surgery. Okay, now all of these sheets look a lot alike. but they're nowhere near alike, so you have to really be careful. So this one says day of surgery. I want you to go to the middle of the page and guess what? Highlight informed consent signed. Go over to the left side, and I'm going fast. Go over to the left side of the page where it says post-op routines. Everyone with me? And put number 1, cough and deep breathe. Go down in that same exact section where it says activity. You see where it says out of bed? Everyone?
Yes.
Now put within 6 hours. What's the best way to get the patient out of bed instead of cussing them out? Take their Foley out. Get out of the bed within 6 hours. Take the Foley out. This is the rule most broken by ignorant nurses who say, oh, she just had surgery last night. Shut up. You about to give her a PE on top of it. Get your patient out of bed within the 6 hours. Medicate them 30 minutes before. Explain why you did it. Did you walk them to California? Hell no. When I say get the patient out of bed, all you did was put them in that chair next to the bed. Please stop trying to walk them down the hall, around the corner to the cafeteria. Sit the patient in the chair. How long are they up in the chair, everyone? Another one y'all would be breaking out in the field. 20 freaking minutes. That be y'all, huh? Jesus, you're killing these people. Get them out the bed. Put them in the chair for 20, 30 minutes maximum, because that's their first time up. Hug them and love them, praise them, and put them back in the bed. Promise them they're only going to be up for 30 minutes, but you don't want them to throw a clot. This is good nursing, and your little funky ass instructors didn't teach you. You wouldn't be talking about no 2 hours. So you got them in a chair, you got 20 minutes. I bring mine cookies, snacks, all kind of crazy stuff. I be loving on my patients, honey, because I know it's hell to get out that bed. So we bring them little treats. You know, I have little sneaky stuff in my pocket. I be hooking mine up. And then they got in that chair for them 20, 30 minutes. I just talk about them when they family come in. I say, oh, you got a soldier, honey. Your girl got up out the bed into the chair. Oh, they love that. It's a big deal. It's huge. You prevent infection when you get them out of bed, because hospitals are full of infection, and if you stick around, you're going to get one. So when you got the patient out of bed, you got her out of here quicker. You prevent bleeding, because when you move around, you circulate blood, blood heals. You prevent clotting, because when you lay up in a bed, you pull. Blood just sits there and clots and moves to the lungs, and this is how we die. The only patients I've ever seen die in childbirth died from either hemorrhage or a PE after a C-section. Get them out of bed. No is not an option. They're going to tell you no, and some of y'all are very nice. Others are like me. The ones is very nice. Let me pull your ear for 2 seconds. I know you learned to be polite. I know you had good family background. You was raised to never ever argue with people. You was raised to never challenge authority. You was raised to do what folks say. You was raised to just say thank you and please. Throw all that shit out. When your patient says no, you turn around and find a yes. And all of them say no. 100% are going to say no. I found a real good trick that worked every time. Because this is what your patient going to say. Oh, honey, you don't know me. I ain't getting out this bed. Yes, you are. No, I ain't. Oh, okay. Well, scoot over. Huh? Scoot over. What you mean scoot over? Scoot your ass over. over. Why? Because I need to get in this bed with you so when you throw this clot, I can run this code. They laugh. They looking at me like I'm serious. Move over. Now, come on now. I got 12 hours, and I ain't leaving this room till we have an agreement. We getting out this bed today. I have not met a no yet because I don't allow it. I've never met that no because we are the nurse. They're sweethearts. They're vulnerable. They're in a lot of pain. But you are the nurse. They love you if you walked in there the right way with a genuine smile that cares. If you address their immediate needs first, you say, sweetie, do you need some water? Are you in any pain? I'm going to be with you. We're going to rock and roll today. I got a lot of things I want to do for you to make you feel better. Then you build that trust and you get their asses out of bed because they're going to fucking die because you're a wimp. They cuss me out. I'm gone. I'm going to grow you some cojones. Cojones. Why she start? Okay, y'all, go on. Keep it moving now. Under pain control. Write down around the clock before it gets severe. ATC. Around the clock before it gets severe. You don't want your patient's pain to get severe because it ain't going to work. Patients don't want you to think they're a drug addict, for real. They don't want you to think they're like all up on drugs and stuff. So they be like going too far, too long without asking for it. And so what we got to the point, and this is what you see at every hospital, we got a dry erase board in every room now. We write when you had it, when you do it again. And that helps them feel better about asking for pain meds. Now remember to put here, once you give the pain medicine, we got to reassess when? 30 minutes. You mess around and miss a compartment syndrome because you didn't reassess in 30 minutes. Once you give the pain medicine, and even before you gave that first dose, right, you checking a pain scale, right guys? We're doing a 0 to 10 pain scale. What number is acceptable? 3. Very good. Very good. 3 is the only number that's acceptable. Everything else needs to be treated in some kind of way. Don't have to be meds, but if it's post-op, of course it should be. Okay? Now, here's one that will throw you a curveball. Substance abusers need more medication. That bullshit you're giving them is like M&Ms. They do that shit all day. So they need more meds. Let me help you with this in case you're confused. You are not Laurelwood. You are not Glen Bay. You are not the drug rehab center. You are a nurse. They can get up off of this shit when they leave you because right now, pain of surgery kills. And they will not get out of bed unless they have less pain. So what's worse? Being back on a little bit of drugs and got to get back off, or dying from the PE and never getting out of your hospital, which is so freaking real. Okay, so they're just gonna need a little bit more to get out of bed, okay? They don't need less, they need more. Okay, babies, now, if you look at the anesthesia, there is something incredibly important in both the regional section and the general section, and that is the blood pressure. You must remember forever that a drop in the blood pressure is a very likely risk with all anesthesia. Now, regional anesthesia, to prevent this drop in blood pressure, you need 500 cc fluid bolus just prior to the anesthesia being given. Not a half hour ago. Immediately prior to anesthesia, you need a 500 cc bolus. That's called preload. A preload 500 cc bolus, IV fluids. Regional anesthesia includes an epidural and this fancy $4 word. Subarachnoid block. What did this used to be called by Big Mama and them? Spinal. They changed the name to protect the guilty. This is a subarachnoid block, because everybody kept saying, I don't want no spinal. Because it's a bunch of little, you know, fear tactics with spinals. So subarachnoid block is a spinal. But people don't know what it is, so they be like, okay. All right, that's what you think I need, all right. Okay, all of them will give you itching. All of them cause pruritus. And I'm talking about real bad pruritus. This patient's going to scratch a hole in their stomach if they, you know, got an epidural for labor. They're going to scratch a hole in their stomach. It's real severe itching. And it can be really severe enough to give medicine for it. But the minute I give you medicine for the itching, I reverse the med. So it's really crazy. Okay, but you need to know pruritus is a big deal. Also, urinary retention. Because if I give you this regional anesthetic, you may not feel yourself have to go. So urinary retention, you're watching the bladder, everybody. What's another complication of a spinal or even an epidural that went wrong? Spinal headache. Spinal headaches are real. I usually get at least 3 people. Anybody in here had a spinal headache? There they are. Boom. 3 people. I could have predicted it, and I did. Okay, so spinal headaches are really bad. They're debilitating. You can't care for your child. You can't take care of yourself. They are horrible. Now, for most patients, we can do caffeine, IV fluids, and lausupine. Now, I'm going to say those slowly because I want you to write them down. Prevention of the spinal headache includes supine position for 8 hours following the spinal. If it was an epidural that was gone wrong, you may have to lay a little bit flat for a little while, not 8 hours, but certainly we try to lay you flat. Okay? Especially if it looked like you're getting a headache. The second thing is fluids, and plenty of them. Lots of fluids, IV fluids, drinking fluids. These 2 help prevent the headache. If you're already starting to get a headache, and as nurses, we're so good about this, we know when that patient looks like they're going to get a headache because we're watching what you're doing with that epidural. And the epidural is not supposed to be leaking out all this fluid. Okay, so we know things didn't go right. Okay, if you're smart, you're watching. You're not doing everything else, you're watching. Okay, then to treat the headache, please know this, caffeine and NSAIDs. Caffeine and NSAIDs to treat the headache. For 50% of people, that shit ain't gonna work. And they're gonna need the worst thing that works so well, but it's not something you can do because it's a serious procedure. It's called a blood patch. And it works so well, y'all. I'm telling you, when they put that blood patch in, that shuts that headache down in about 15 minutes or even sooner. And let me explain what they did. Wherever the spinal was done or the epidural was done, the reason why your head is hurting is because you're leaking fluid. And whether I can see it or not, it's leaking. In order for me to prevent any more leaking, that's why I kept you supine. Because the more you standing upright, you leaking. So I kept you supine so it can heal over and clot over. And also I kept giving you fluids because you're losing fluids. Because your brain works on a very sensitive type of principle. It's called the Kelly-Monroe principle. It works on a very sensitive principle. If something goes down, something else better go up. So I gave you fluids to keep what you're losing balanced. That didn't work though. This patient's still suffering. So then I gave you medications that vasoconstrict. Prostaglandins, which is your NSAIDs. Okay, we want to inhibit the prostaglandin. We're trying to stop it. Okay, so if we vasoconstrict, we cut off the fluid. If that doesn't work, and sometimes it doesn't, now we got to do a blood patch. That's a mechanical procedure. Let me explain. We draw a tube of blood from here, and we inject it back in here to clot off the leak. As soon as we're done, your patient says, oh, I don't have a headache anymore. Who had it happen just that fast? Anybody? You had a blood patch?
I did.
And how fast did it go?
Immediately.
Immediately. Immediately. You can't do it. That's what you got to remember in this procedure. Only anesthesia should be doing this. Yes. Well, I mean, we're going to draw it here. That's where we draw blood. Yeah. Yep. And we inject it back in the back. Now, we don't do it again. But you need to call them. Blood patch. You don't do it. Anesthesia does it. Go over to the general. Highlight that low blood pressure. Highlight the vomiting. Highlight the hydration. Now, vomiting. Ain't that why we tell them NPO after midnight, everybody? Okay. Hydration, same reason. Volume controls blood pressure. Turn the page. Analgesia versus anesthesia is really, really easy. You're going to highlight what I tell you to highlight, but at the very top of the page for anesthesia, circle it and write low blood pressure. Write low blood pressure because that's the focus of all anesthesia. For analgesia, circle it and put reassess in 30 minutes. A lot of this is repeat, which is nice. Okay, now look, key points. Epidural analgesia, key points. Highlight itching and remember pruritus. Highlight urinary retention and put watch the bladder. Now, epidural analgesia is like having a PCA pump that's attached to the catheter in your back. We have that a lot. Epidural anesthesia is going to be an anesthetic that is hanging and going into your catheter in your back. And for this one, I want you to put monitor for blood pressure and respiratory because it's anesthesia. Respiratory, yep. Turn the page.